This is Chapter 19, Part 2, and we're continuing on with burns. So who is our population that we're concerned about that's vulnerable right now? It's most commonly seen in younger adults. If burns are seen in older adults, they are most likely to die. On page 19, on table 19.3, it talks about the different types of burns. On clinical presentation, you may have some superficial burns, some superficial partial thickness burns, which are greater than 25% of the total body surface area in a 10 to 50-year-old, or greater than 20% in an adult greater than 50. Full thickness burns are greater than 10% on any individual. And then if there are serious burns to the face, hands, feet, or perineum, those are indicative of being transferred to the hospital. Burns complicated by inhalation therapy, hospital. Electrical burns, go to the hospital. So major burns are managed in the emergency setting. They need to be transferred to a burn unit, as we talked about on the previous slide. Also, any burn in an infant, an immunocompromised individual, or an elderly patient needs to be assessed at a burn center. We measure burns by the rule of nines, and so if you look at this is the burn percentage on adults. Children are different, but depending on where your patient's burns are, depends on what percentage of their body that might have sustained burns. Initial management is like any thing. We need to do the ABCs. We need to make sure they have a patent airway. We need to make sure that they're breathing, monitoring their O2 sats. We need to look for signs and symptoms of inhalation injury, whether there's facial burns, whether there's soot around their mouth, their nose, if when they cough up sputum that it is tinged with brown or black, if we have singed nasal hairs, coughing, as we talked about, if we have signs of hypoxemia, difficulty breather, whether we're showing stridor or retractions. And then also as the burn process is utilizing a lot of fluids, we need to offer fluid resuscitation. Somehow this slide got out. The previous slide, it looks like we're a little out of whack, and I apologize for that. Let's just briefly go over this on burns. This on bites. So for animal or human bites, it's very important to clean the area and irrigate it well, and you will need large volumes of normal saline or water to clean with. It has been found that, as we all know, that betadine and peroxide can damage tissue more by using those than just water or normal saline. If there's a laceration to the face, that needs to be closed by someone, typically in plastics or the emergency department. For any patient that you've had that has suffered an animal or a human bite, you need to assess where their tetanus status is. If none has not been done within the last 5 years, it's important to re-immunize. If someone has been bit by a dog, it's important that they are referred to the health department to see what steps need to be taken to have that pet observed to rule out any issues with rabies. Cat bites and high-risk dog bites and human bites are treated with Augmentin for 5 days, and then human bites are also given a post-exposure HIV prophylaxis. It's important to educate your patients on what to call for, to elevate the affected area, to decrease swelling, call for signs and symptoms of redness, fever, and any drainage that might be of concern. So we have with dogs, we have an increased risk of infection of 3 to 18%. With humans, up to 50%, especially in joint areas. And then also you have increased risk of HIV or hepatitis B. With cats, you have a 28 to 80% risk of infection with a puncture wound because they are known to carry an organism called Pasteurella multocida. Prophylaxis is offered for puncture wounds of the hands and ones from cats and human bites, and you would treat with Augmentin or Cipro plus clindamycin. Augmentin or Cipro, then add clindamycin to that as well. We can also be bitten by bugs, and that can cause some different reactions based on the bite and their venom. So some vesicating toxins include different beetles, caterpillars, multipeds that can produce blisters. Neurotoxins could be from black widow spiders, scorpions, ticks, from different bumblebees. Also, cytotoxic or hemolytic toxins can be from mites, chiggers, brown recluse spiders, and hemorrhagic toxins could include lice, fleas, ticks, mites, and biting flies. When you're treating with these, it's important to assess the reaction from the insect bite. You can expect a large local reaction. This is normal to have redness and pain and swelling and itching, and it should get better in the first 1 to 2 hours. You can also have some systemic reactions or have release of IgE, and you can have a type 1 immediate hypersensitivity response. There are also delayed reactions that you can have with IgG or IgM, and it's important to follow those. So if you have a large local reaction that's greater than 6 inches, it's likely going to peak at about 48 hours, but it could last for as long as a week. And you could have if you have a history of a large local reaction that is not typical, you also can have this associated with anaphylaxis. You can have some toxic reactions from multiple stings that occur greater than 10 stings at a time. So it's important to, once again, learn about the history of the bite and what they've been bit by, where they were, how often they think they've been stung, etc. Sometimes due to concerns for anaphylaxis, you need to be prepared for emergency management, having oxygen, epinephrine, antihistamines, circulatory support such as IV fluids and steroid therapy. Those patients will require follow-up and referrals, and it's important that if they've had an anaphylactic reaction that they have a prescription for an EpiPen, and they may need a referral to an allergist. In regards to head trauma, there are some different types. We have cerebral contusions, concussions, skull fractures, epidural hematomas, and subdural hematomas. And we'll talk about these a little bit more in detail. So your patients that are at high risk for head injury, those include patients that are on anticoagulants or have bleeding disorders, those that have sustained a change in consciousness, altered mental status. If you are concerned for somebody to have had suspected alcohol or drug consumption, if we have repeated vomiting, if we have a Glasgow Coma Scale that's less than 15, if someone's greater than 60, or if you are noticing battles or raccoon signs. And we'll talk about those, but the battle sign is that bruising that comes on the behind the jaw, below the ear, in the mastoid process part, and then the raccoon sign is the circles that go around the eyes. It's important with head trauma to do a thorough assessment, and there's more key tips on that on page 1178. It's important to conduct the Glasgow Coma Scale, and that's spelled incorrectly, but you're assessing 3 areas: eye opening, motor response, and verbal response. So I know that those individuals that have spent some time in the ICU, CCU are familiar with that ER as well. A score of 15 is considered normal, 7 could be unconscious, and 3 is in a deep coma. And it's important to perform the Glasgow Coma Scale every 2 hours to assess for changes. So something else that we follow with head trauma is early signs of increased intracranial pressure, whether your patient is having a headache, nausea, or vomiting, if they're not remembering what has happened previously, altered level of consciousness, changes in speech, drowsiness, agitation, if they're making choices that would not be typical for them. Some late signs of increased intracranial pressure included dilated, non-reactive pupils, unresponsive to verbal or painful stimuli, abnormal posturing patterns, increased systolic BP resulting in a widening pulse pressure, and decreased pulse pressures, and changes in respiratory rate or pattern. So the assessment of these type of patients that may have had some type of skull fracture include Hemitympanium, which is blood in the tympanic cavity when you're looking in their ear. We talked about the battle sign, which is the mastoid ecchymosis, the raccoon sign, which is periorbital ecchymosis. This is supposed to say CSF rhinorrhea, where we have a leak of CSF that comes as a drippy nose. And then also you can note that there are alterations in their cranial nerves in 1 through 8. Some diagnostic testing that may occur is wakeful watching, and that's perfectly appropriate depending on what's gone on. Assessing the Glasgow Coma Scale, you may see someone do a plain CT, an EEG, or an MRI. So patient education is important, and it's important to make them aware that they don't need to be by themselves in the first 24 hours. They need to be aware of keeping up with quiet activity and a light diet. They need to be awoken every 2 hours just to assess their cognition. If their patients note that there's or their caregiver that there's increased vomiting, inability to move arms or legs, a temperature greater than 100, stiff neck, pupils of equal size or shape, if they start having severe headaches, convulsions, confusion, any disorientation, that those are symptoms to seek medical help for, i.e. go into the ER. All right. So we're going to talk a little bit about musculoskeletal trauma, and there's some different ones that you may see in practice: strains, sprains, fractures, and we're going to talk about a little bit of diagnostic tests and differential diagnoses. So as older patients get more mature, they tend to have more overuse of injuries, whether that's in their ankles, their knees, plantar fasciitis. We can also have learned that occupational injuries are more likely on Mondays and more likely in the first 4 hours of an individual shift. There are also 3 main peak times when fractures occur. It's more seen in young adult males, in older adults, and then there's also an increase in fractures, especially of the wrist, in women over the age of 40. So a strain is defined as macro or micro tears or stretching of the muscle fibers. A sprain is described as stretching or twisting beyond normal range of motion for that area. It's impossible to determine the difference between a strain and sprain on physical exam. Injuries, though, to joint areas are usually sprains due to the ligaments in that area. If you're concerned, it's important that you do an x-ray of the affected area to rule out a fracture, especially with change in range of motion, increased swelling. You also need to consider different differential diagnoses, including musculoskeletal trauma, that might help you determine if there's a bone fracture versus sprain or strains. I think this is a great website. It's from the American Academy of Radiology, and I've just given a clip there. But if you go to this website and you click down, I believe it's about halfway down, and there's a button to click on called Basic Testing. They have it broken into different body parts that you might use for assessment purposes and what radiological tests that you can use. This is on musculoskeletal, and it says, so if you have someone that has pain of the ankle, what test do you do? Why would you do that? What is the supporting evidence of it? So there's a lot of great factual information over here in these links that are PDFs to help support why you would choose the test that you chose. I found that was a very good site on helping you decide what test to do. All right, so back to musculoskeletal traumas. It's important that how we take care of those issues is typically with RICE. Rest, ice, compression, elevation, and of course offering what you might need for pain management. Non-steroidals are very good at this point, but these things often take time, and having the rest is the best thing for them. But offering your patient RICE plus some pain management is very beneficial. We're going to talk briefly about some fractures. Further on in the slide deck, there's pictures of different types of fractures, and I'll review those briefly, but you can go back and look at those with more description later. So we can either have closed or open fractures. Closed is when the skin is not broken and likely would require a cast to realign that bone so it could heal. Open fractures are where the bone is broken through the skin. With these fractures, you have increased risk of infection, which could be life-threatening, depending on what type of infection it is and where the bone is. These typically require surgery, hospitalizations, and the use of IV antibiotics. You can also have incomplete fractures where only one side of the bone is broken, and you might see that in a hairline or stress fracture or a green stick fracture. A complete fracture is where both sides of the bone are broken. We have different fracture descriptions, and once you've described the fracture as either open or closed, complete or incomplete, then you describe the fracture based on its shape. And there's different ones that we'll see: stress, green stick, epiphyseal, transverse, impacted, oblique, spiral, comminuted, avulsion, and compression. So we have a green stick, and these are pretty self-explanatory, but you can see where the break is not complete. We have a transverse fracture where the bone breaks completely through from right to left in a transverse plane across the almost like a straight line across. We have an oblique fracture where it typically goes from an upper point to a lower point, and we're at an oblique plane. We have a spiral fracture, and this fracture is almost like someone has put a hand here and here and twisted. Okay, it's often seen in sports fractures. We have a comminuted fracture, and that's where it's in 3 or more pieces. It's kind of hard to see here, but on the diagram you can see better the different parts of the fracture. Here we have an ankle fracture where the tendon has been pulled off a piece of the bone. This is a fracture of the femur where a person fell from some height and the head of the femur jammed into the neck of the femur. We have compression fractures where we have crushed vertebra, and you can see this here on radiology and then here also on the diagram. This is a picture of a fracture of a scapula, so you can see how this part of the scapula has been fractured and then what it would look like here in the x-ray. We have a clavicular fracture. This is all supposed to be one in a gentle arch, and we can see where we fractured there. Another fracture here and here. Annually, there's 1.5 million fractures. We can have greater than 700 vertebral fractures, greater than 300,000 hip fractures, greater than 200,000 rib fractures, and there's various and sundry other fractures that make up greater than 300,000 other fractures. One last thing before we close on this chapter is musculoskeletal trauma. You will see this in practice, lower back pain. 80% of the population at some point may say that they have lower back pain. Some differential diagnoses would include degenerative joint disease, disc herniation. You could have metastatic cancer. Things that you need to be concerned about is if you're having the spread radiculopathy, so the nerve conduction impingement that focuses out, if you're having fevers. Chronic diseases increase the risk of lower back pain. Increased history of smoking, weight loss, older age, diabetes, cancer, spinal abscesses. You need to be concerned if the lower back pain is unrelieved by rest or lying in a supine position. There is a condition called quota equina syndrome where there's impingement of the nerves down in the lower component of the spine. You have leg weakness, you have paresthesia in the saddle area. So if you think about the girdle of the hip and in the pelvis area, you have different sensations there. If you notice that your patient is having bowel or bladder incontinence or issues with impotence, and these are not typical symptoms, then those are things to investigate. We can also see some ankylosing spondylitis, which is low back pain that worsens with rest but seems to improve with activity. The majority of patients with lower back pain will improve in 1 to 4 weeks, and it's important to use conservative treatments such as NSAIDs. Bed rest is not recommended. It's important to get patients up and moving, and then also to use ice or heat. It's important to use proper body mechanics, lift with your legs, push, not pull, don't twist, stretch every 1.5 hours, wear flat supportive shoes, and do core strengthening exercises. I'm a firm believer if you've got lower back pain, you don't need to be in high heels, you don't need to be in flip-flops, but you need to be in some lace-up shoe, and I typically encourage folks to be in tennis shoes so that the feet support the rest of quote-unquote their chimney or their support system in their body, and their knees are in better alignment, their hips are in better alignment, their back then is in better alignment, neck, etc. All right, so that's the end of chapter 19, part 2, and I appreciate your time.